Okay, let's get into it. We're looking at mitral regurgitation today, often just called MR.
Right.
Think of the mitral valve in your heart, like a one-way door. And your notes detail how sometimes this door, well, it leaks.
Exactly.
So our mission here is to pull out all the really crucial bits about MR from these notes, make it super clear, memorable for you listening. We'll hit what it is, the causes, risks, how it affects things, the essentials.
And it's worth knowing right off the bat just how common MR actually is. Fundamentally, it's blood flowing the wrong way backward from the left ventricle, which is the heart's main pump,
Right.
back into the left atrium. And this happens when the heart contracts during systole.
Okay.
And maybe surprisingly, it's the second most common heart valve disease out there, right after aortic stenosis. So yeah, it's pretty significant clinically.
Second most common. Wow. Okay. Definitely need to understand this then.
Mm.
Now, your notes talk about acute versus chronic MR. What's the key difference there we should remember?
Yeah, the main thing is how fast it happens. Acute MR, it comes on suddenly, often triggered by, say, an infection like endocarditis, or maybe issues with the muscles holding the valve, or even if the ventricle suddenly stretches. Think, acute equals abrupt.
Gotcha.
Chronic MR, though, that's different. It sort of creeps up on you, develops gradually over time. Often it's down to wear and tear on the valve, like in mitral valve prolapse, or maybe problems with the whole support structure. Sometimes linked to connective tissue stuff. Those are definitely exam buzzwords to know.
Right. Acute is sudden, chronic is slow burn.
Yeah.
And you mentioned it's not always the valve itself. Sometimes it's the surrounding bits.
Precisely. We tend to classify MR as either primary or secondary. Primary MR means the valve itself, its structure is the problem. Maybe a leaflet is floppy, Secondary MR, which we also call functional MR, is where the valve is usually structurally okay, but the left ventricle, the main pumping chamber, is maybe enlarged or weak, and that pulls on the structure supporting the valve, causing the leak.
So it's like a perfectly good door, but the frame it sits in is warped.
That's a great analogy, yeah. The door's fine, but because the frame's off, it just can't seal properly.
Okay, that makes sense. So let's dig into the why. Your notes break down the causes, again, into primary and secondary.
Yeah, and for exams, it's useful to keep these separate in your head. Primary causes are direct valve problems. Mitral valve prolapse, where a leaflet kind of billows back, like a parachute not quite opening, right? That's a really common one.
Okay.
Then there's rheumatic heart disease. Bit more historical, maybe, but still relevant. That's damage from strep throat complications.
Right.
Infective endocarditis, an infection actually attacking the valve. And, of course, congenital defects, so problems someone's born with.
Okay, so those are all direct hits on the valve leaflets or structure. What about secondary causes then? What's going on there?
So secondary causes, remember the valve itself is usually normal, but it leaks because of issues elsewhere. The big driver here is often left ventricular dysfunction or dilation.
Meaning the main pump is weak or too big.
Exactly. Maybe from a past heart attack, that's ischemic heart disease, or a condition like dilated cardiomyopathy. When that main chamber gets weak or stretches out, it pulls the whole mitral valve apparatus out of shape.
Like stretching a rubber band too much?
Yeah, precisely. It distorts it so it can't close properly. And again, for exams, don't forget the rarer causes like myxomatous degeneration. You see that in connective tissue disorders like Marfan's and Ehlers-Danlos, also certain drugs, even heart tumors sometimes.
Got it. Direct valve trouble versus the whole heart structure being off. Now, who's more likely to get misformed? What are the key risk factors we need to flag?
Good question. Knowing the risks helps identify who might be susceptible. Age is a big one. Like any mechanical part, valves can wear out.
Makes sense.
Interestingly, female gender is also noted as a demographic factor. Conditions putting strain on the heart, like high blood pressure, hypertension, definitely increase risk. And having a history of those primary causes we mentioned, rheumatic heart disease, endocarditis, that ups the risk too. Same if someone already has mitral valve prolapse or has had previous surgery on the valve.
Right.
Underlying heart conditions like ischemic heart disease or cardiomyopathy are major risks. And again, those connective tissue diseases pop up. Even kidney problems, renal dysfunction can play a role.
So quite a mixed age, other health conditions, even some unexpected links like kidney issues. Now, let's get into the mechanism. What's actually happening inside the body when that valve leaks? The pathophysiology.
Okay, think about it step by step. The valve doesn't close tight during systole, right? So blood flows backward into the left atrium.
The wrong way.
The wrong way. This backflow creates essentially a traffic jam. It increases the volume and the pressure in the left atrium, and that backs up into the blood vessels coming from the lungs, the pulmonary circulation.
Ah, okay. So that's where the lung symptoms might come from later.
Exactly. Now, to cope with this backflow and still get enough blood out to the body, the left ventricle has to work harder. It pumps more blood with each beat. Over time, this makes it get bigger and thicker. That's dilation and hypertrophy.
So it's compensating.
It's compensating, yeah. But that compensation can't last forever. Eventually, that overworked ventricle can start to fail, to weaken, and that leads towards heart failure. It's like, imagine constantly trying to bail water out of a boat that has a leak. You can keep up for a while, but eventually you just get exhausted.
That's a really clear way to picture it.
So how does this actually show up for a patient? What sort of symptoms might someone experience?
Well, the symptoms are the body's signals that something's wrong.
Hmm.
Fatigue and weakness are common just because the heart isn't pumping blood around as efficiently.
Less oxygen getting delivered.
Precisely. Then there's breathlessness or dyspnea, especially noticeable when you exert yourself, or sometimes when lying flat, that's orthopnea, or waking up gasping for air, paroxysmal nocturnal dyspnea. These are really classic signs of fluid backing up into the lungs.
People might also feel palpitations, like their heart is racing, fluttering, or skipping beats. Sometimes a cough, maybe with pink, frothy sputum if there's significant fluid in the lungs. And then more general signs of heart failure, like swelling in the legs, edema.
So quite a range of things someone might notice. And what about on examination? What might a doctor pick up? What are the signs?
Okay, the absolute classic sign, the one you really need to remember for exams, is a specific type of heart murmur. It's called a pansystolic murmur.
Pansystolic.
Meaning it lasts throughout the entire contraction phase, systole. It's often described as having a blowing quality. And crucially, you hear it best at the apex, the bottom tip of the heart, and it radiates, it spreads towards the armpit, the axilla.
Apex, radiating to the axilla. Got it.
That's the one. You might also feel that the point where the heartbeat feels strongest, the apex beat, is shifted over to the left, which suggests the left ventricle is enlarged. Other potential signs? Well, you might hear crackles in the lungs if there's fluid buildup, pulmonary edema. Maybe signs of an irregular heart rhythm like atrial fibrillation. You'd feel an irregular pulse. And sometimes a louder second heart sound component called P2, which can suggest high pressure in the lungs.
Okay, that murmur is definitely the key takeaway there.
Yeah.
So once MR is suspected, how do doctors confirm it? What tests are typically done?
The gold standard, the #1 test, is the echocardiogram.
The heart ultrasound.
Exactly. It lets us see the heart valves directly, see how they're moving, assess the structure, and we use Doppler, which is part of the echo, to actually see the backward flow of blood and measure how severe it is. It gives us loads of information.
Right.
A chest X-ray can also be helpful. It might show if the heart is enlarged or if there are signs of fluid congestion in the lungs. An ECG electrocardiogram checks the heart's electrical rhythm. We look for abnormalities like atrial fibrillation or signs that the chambers are enlarged, like left ventricular hypertrophy. Sometimes you see a specific ECG finding called P-mitral, a shape of the P wave suggesting the left atrium is enlarged.
P-mitral, okay. Another one for the exam list.
Definitely. And sometimes, maybe less often, more detailed or invasive tests might be needed, like cardiac catheterization or a cardiac MRI. Oh, and blood tests, like measuring BNP levels, that's brain natriuretic peptide, can help gauge the severity and stress on the heart.
So echo is really king, but other tests help build the full picture, right? Once it's diagnosed, what can actually be done? How is MR managed?
Management really depends on how severe the MR is and whether the person has symptoms. For milder cases, or to manage symptoms, we use medications, things like diuretics or water pills, to help reduce fluid overload and ease breathlessness. Medications like ACE inhibitors or beta blockers might be used too, especially if there are signs of heart failure or the ventricle isn't pumping well. In really acute, severe MR, more intensive medical treatment might be needed quickly in hospital.
And what about fixing the valve itself?
Yeah, for moderate to severe or severe MR, especially if it's causing symptoms, surgery is often the main treatment. The options are generally to either repair the person's own valve or to replace it with an artificial one.
Is one better than the other?
Generally, valve repair is preferred over replacement whenever possible, particularly for degenerative MR that wear and tear type. It often leads to better long-term outcomes and avoids the need for lifelong blood thinners sometimes required with mechanical replacement valves.
Right.
And if someone has acute, severe MR, that's usually a surgical emergency. They need urgent surgery. There are also newer, less invasive techniques emerging, percutaneous repair options done via catheters. And it's important to note, sometimes surgery is recommended even if someone doesn't have symptoms. If tests show the leak is severe and the heart is starting to enlarge or weaken significantly, like a reduced ejection fraction or the left ventricle getting too big, we want to intervene before irreversible damage occurs.
But not if the heart's already too weak.
That's a key point. If the heart's pumping function, the left ventricular ejection fraction, or LVEF, is already very poor, typically below 30%. The risks of surgery often outweigh the potential benefits, so it's usually not recommended then.
Okay, so medication for symptoms, surgery to fix the leak, ideally repair, and timing is crucial. What's the general outlook for someone with a Marfan, the prognosis?
Well, the prognosis really varies. Generally, the best outcomes are seen when we intervene early, especially in people who don't have symptoms yet but have indications for surgery based on severity and heart changes.
Early detection again.
Absolutely.
Yeah.
MR can be serious, particularly if it leads to significant left ventricular dysfunction, and untreated acute severe MR, as I said, that has a poor prognosis.
Are there factors that point towards a worse outcome?
Yes. Several factors are associated with a worse prognosis. Things like older age, having atrial fibrillation, just the sheer severity of the regurgitation itself, developing high pressure in the lungs, pulmonary hypertension, having a very enlarged left atrium or ventricle, and a low ejection fraction. Also, MR that's caused by coronary artery disease, what we call chronic ischemic MR, tends to carry a poorer prognosis too.
Right, so multiple factors play into the long-term outlook.
Yeah.
And finally, what are the potential complications if MR isn't managed well or progresses?
Well, several serious things can happen down the line. We've touched on some pulmonary hypertension is a big one. Progressive left ventricular dysfunction and enlargement, eventually leading to heart failure.
Okay.
Atrial fibrillation, that irregular heartbeat, which significantly increases the risk of stroke because clots can form in the atrium. So thromboembolism is a risk. There's also an increased risk of developing infective endocarditis, an infection on the already damaged valve. And as mentioned, the ultimate common pathway for many of these issues is congestive heart failure.
So that leaky valve really can cause a cascade of problems throughout the heart and lungs. Okay, let's try and summarize the key takeaways for you, especially thinking about those exams.
Yeah.
Mitral regurgitation, MR. It's common, it's important. Remember that classic exam finding. A pansystolic blowing murmur, best heard at the apex, radiating to the axilla.
Definitely know that one.
And remember the key causes, like mitral valve prolapse, rheumatic heart disease, endocarditis, and importantly, secondary causes related to left ventricular problems. Think about the distinction between acute and chronic presentation.
And echo being the key diagnostic test. Management involves meds for symptoms, but often surgery, ideally repair for significant MR, considering symptoms and heart changes.
Exactly. It's about catching it and managing it appropriately to prevent those complications like heart failure and AFib.
Couldn't agree more. Early detection, appropriate management, that's the key for better outcomes.
Right. Well, hopefully that's given you a really solid high-yield overview based on your notes. For a deeper dive, more questions, and resources specifically tailored to help you ace those exams, definitely head over to passthemsra.com.
Yeah, lots of great stuff there. And don't forget, there are free materials available too over at freemystery.com, which are always worth checking out.
Absolutely. So that's been our deep dive into mitral regurgitation. Thanks for tuning in, and we'll catch you next time.